We are fortunate to have Dr. MacDonald here tonight and Kathy McGovern here tonight, the Williamson County Health Department and the regional health officer for the state of Tennessee, and a specialist really in infectious diseases, in the study of that. And I'm going to be quiet so you can have even more time. We need to hear what you have to say, and we can ask questions too. Right?
Oh, sure. As I go along, feel free to jump in and ask questions. Just to explain what the health officer is, Kathy is the county director for the Tennessee Department of Health clinics in Williamson County, which is Franklin and Fairview. And we have our region, which we like to tell everybody is one of the best regions in the state, is the 12 counties around Metro Davidson. We are not Davidson County, that's a Metro Health. We're all the rural counties around. So we're responsible for your well-being as the public. For example, if there was a food outbreak in one of the restaurants and people came down with some type of salmonella or norovirus or whatever it might be, we'd be the ones that would collect the appropriate laboratory specimens, figure out what it is, find all the contacts, hunt you all down, treat you, and make sure you're fine. And we're also there to protect the health of the public. So we're all about protecting people and giving information out so that you could be safe. And I think we do a pretty darn good job at that. But of course, Ebola has become a huge topic, and there's a lot of moving parts with Ebola. There's the federal government, the Center for Disease Control, there's state government, there's local, regional government. Just think about there's hospital systems, there's the emergency medical service system. If you showed up at one of our clinics, for example, and said, I've just been to Liberia for 6 months and I don't feel so good, what's going to happen? Well, we pretty much have got it down what would happen, and we have to interact with all those other moving parts so that nobody kind of messes up on the way. And so what I want to kind of talk about is just like what is Ebola and how did it start? They don't really know, but they've got some pretty good ideas. And where we're at with it, how it spreads, what it causes people to do, why is it so deadly? We've been pretty successful in the United States treating it. We just had our second death this morning. Dr. Salia, who's a surgeon who is a U.S. resident but was born in Sierra Leone, he was transferred to the Nebraska Medical Center over the weekend, but he was in pretty rough shape when he landed. And as the guide, I just heard the fellow that was taking care of him speak, and he said there comes a point when you get clinically to the point of really no return. There is nothing you can do. And he was given all the experimental drugs, transfused with previous survivors' blood, etc. But it was a little bit too late for him, which is unfortunate. So that was our second death. But I'll just go through that. But feel free, if I say anything that confuses you, which is quite possible, feel free to just ask questions, and I'll answer them as best I can. So this is what we're going to talk about, is just the epidemiology, the numbers, what our response is. I think is really important for people to know, because it's scary. And once you realize what we're actually doing in conjunction with the federal government and the CDC, people get really calmed down a lot. We're going to talk a little bit about the treatment and some of the new stuff out. There's some new things being tried. Some of it is still experimental. However, it looks good. And we're going to talk about vaccine, which is around the corner. That's the key, and we're all about vaccine, preventable disease. So this is, you've probably seen this picture. It's become quite famous, but that's the Ebola virus. It's a filovirus, because it looks like a little filament. And there's 5 subtypes, and it's been around for a long time. Its first case was 76. And if you look at all the cases up until now, you'll see that it's sporadic, 2 or 3 cases, 1 death, and then nothing for several years in Africa, and then it all happens that you'll have a little cluster, and then it'll kind of go away. And the question is, why is that? And some of that has a lot to do with how we can move so freely about in crowded areas and how contagious diseases spread. The Zaire type is the type that we're talking about here. So this is one of my favorite slides. These are the little fruit, they're not little, they're big bats, they're fruit bats. And they're the likely reservoir. So we think that what's happened is humans, how did it get from animals to humans? It's likely through the fruit bats. So they roost in large colonies, and I guess they like to hang upside down a lot. They feed off of primates in the jungle as well as wild antelope, which people then slaughter and kill. Like you'll hear about bush animals, that's what they're talking about, people eating bush animals. Also, they are fruit bats, so they eat fruit, and they salivate on them and urinate on them. And if the first case was a 2 or 3 year old boy back in '76 who apparently ate fruit that had been spit on by the bats, is what they're thinking, and that's how it started. Nobody knows for sure, but that's the theory behind it. So here's kind of a picture of how it happens. There's the bats flipping around. They come down and jump on these guys, and they eat the fruit. And so bats to the animal reservoir and then the human reservoir. That's why you'll see a lot, if you read a lot at all about Ebola, they're asking the people in West Africa not to eat wild animals and not to, eat fruit that's not washed. I mean, it's very simple public health things. Wash your hands. You'll hear us say that through the whole flu season. Get your flu shot, wash your hands. Those are the two, and cover your cough. Those are the two big things, although cover your cough's not that important for Ebola, and we'll talk a little bit about that too. So what happens when you get it? The incubation period can be, so if I'm infected, within 2 days typically, and I think days 4 to 7 are when most people start to really get sick. The longest one was one guy that was watched who had been in contact with a case. On day 21 developed the symptoms, so they've had to make the earlier slide was shorter, now they've gone out to 21 days, which is why you'll hear the 21 day. You've probably heard about the nurse who didn't want to stay in for 21 days. That magic number 21 comes from after 21 days, no one's ever contracted the disease that has been exposed. So 21 days is pretty safe, but most likely in the first several days is when you're most likely to get it. And it's a virus. You get fever, headaches, sore muscles. Unfortunately, they also have a lot of malaria in this area, and some of the symptoms are very similar. So it's hard to, every time someone gets a fever, people are like, oh, they've got Ebola, but most of the time it's malaria. So that's, it can present like many other things. Interestingly, hiccups, apparently, they've noticed that people early on in the illness hiccup a lot. And so now they're looking at, so if you come in with a fever in West Africa and you're hiccuping, I think they quickly put you in another room. And then you get the nausea, vomiting, abdominal pain, diarrhea. And the thing with the vomiting and diarrhea is, and I've never seen it, but people say it's amazing volumes. And that's very filled with the actual virus. And so, of course, if you're the grandmother in West Africa taking care of your 4-year-old grandchild who's sick, who cleans up everything? Grandma does. And that's how, I don't know about you guys, but my kids, if they were ever going to throw up, it was always on me. It was never anyplace else. And so, and the fluid is filled with the virus. The other thing about this particular virus is early on, what we call the viral load, you can actually measure how much virus is in the blood. We do a test for lots of viruses called viral load, like HIV. I'm an HIV provider, and I'll test their blood to see how much virus is in there. And if they're treated and well controlled, the lab comes back with virus not detectable. Or it'll come back with viral load 1,600,000. That's not so good. That's a lot of virus in that blood. The thing with Ebola is that the viral load in the first few days is low, which is why people who are actually sick don't transmit. If you remember Mr. Duncan, who came to Texas, he walked into that hospital and he said, I'm sick, I have a fever, I live in Liberia, and I've been with people that are sick, and they said, yes sir, have a seat in the waiting room and we'll be right with you. 48 people were sitting next to him. So he was already infected at that point. They called him back, they gave him an antibiotic and sent him home. He came back 1 or 2 days later really sick, and that's when they admitted him, and you know what happened from then on. Every one of those folks that had any contact with him were tracked down, and that's what public health does a lot of, contact investigations. We find people who were contact to an ill person and then follow them until they're safe. Not one of those folks contracted the disease. So his viral load must have been pretty low early on. And by the time he ended up in hospital, that's when it got high, and the 2 nurses were infected, both of whom admitted that they inadvertently breached protocol in taking off their protective gear. The first nurse did that with the secretions and the virus, and if you have any break in your skin, and he was apparently, I mean, if you read the New England Journal of Medicine, they go through his case. This man was sick. I mean, he was on dialysis, he was on the ventilator, they had trached him, so he had horrible diarrhea like people had never seen, just everywhere. So, you know, you're mopping it up, cleaning it up, and if you're not perfect with your protective equipment, you're really at risk. So we kind of learned that lesson the hard way. We don't have any cure, obviously, it's a viral illness, but as the illness goes on, you start to get organ failure, just like you can with any other bacteria or virus that overwhelms us. Jaundice if the liver's involved, pancreatitis, and then it gets into the central nervous system, and pretty soon you're comatose. It chews up all the blood clotting factors in our blood, so that's why you start to bleed. People bleed from their eyes, their nose, their mouth, and there's not a whole lot you can do when you get to that point. And we see that with other overwhelming infections, a similar kind of thing, but not quite as dramatic as this. As you can imagine, when you lose all that fluid, you lose your sodium, so you get your potassium goes down, you get heart arrhythmia. And I think the reason we've been more successful at treating Ebola in the United States just with supportive care is that we can measure that stuff so easily and replace it so well. Every ICU in this country can replace electrolytes quickly. We can measure people's volume with intravenous lines that have special little measuring apparatuses to make sure that their pressures are correct inside their blood vessels. They just don't have that in West Africa. Once you get the low platelets, that's when you start bleeding. And the fatality rate has been around 50%, primarily because they just in the West Africa they don't have enough facilities to provide the care. I mean, right now we can take care of it at the hospitals here that we've identified, which are Emory, Nebraska, Bethesda, there's a couple other ones, one in New York City. We're looking at about 5 or 6 patients per facility. So that's 30 that we could handle in this country. They had 14,000 cases. So where are these folks going to go? I mean, hospitals just turn people away. They just say, we can't take you. We don't have enough of anything. We can't help you. So that's why the fatality rate was so high there, and it has not been high in the US. And this is the countries, the West African countries. So you've got Sierra Leone, Liberia, and Guinea. Now, that landlocked country just a little bit to the east of Guinea was just added, that's Mali. So that's just, the CDC just added that as a country. We don't have that one highlighted yet. A young child whose mother died was sent to grandma in Mali, and grandma took care of him, but he died and she got it. So that's how it spreads. Yeah.
I'm just going to ask, I read some books on Ebola, like I think the Belgian nuns were there like in 1976, and I was under the impression that it was like a local thing that, you know, kind of burned itself out in like a village or two. So what's the difference between, you know, then and now that it's, you know, spread so much?
I think the biggest difference has been the density of the population in the area that it's come to. Because in the more sparsely, back in the 70s, there were smaller villages. And actually some of them did really good jobs at handling it themselves and making sure things didn't spread. Now we're into bigger cities where the actual ability to be mobile is huge. I mean, people are using mass transport, they're sick, and they're spreading it by actually our technology allows us to get from point A to point B. And I think in the 70s, people pretty much stayed to themselves. Now, they're in Liberia. To the south is a huge rubber plantation that is owned by Firestone. I don't know whether anybody has heard about this. The Firestone plantation, there's been no Ebola there. And then it's a compound that has, I think 40,000 people live on the compound, and they say that all the trees bow towards Akron, Ohio, because that's the headquarters of Firestone. And I was just listening to NPR when I was driving here, and way back, I can't remember how long ago, the fellow that bought the property in Liberia paid a cent an acre, and he bought 6 million acres. What a deal. So that was the biggest, it's the biggest rubber plantation. So this lady came back from visiting a family member in Liberia where Ebola was and brought the disease back. And the doctor there, he was pretty funny actually. He sounded like, well, heck, I don't know much about this, but we could isolate this lady and her family, and they did. And they built their own facility on the plantation, because I'm sure they have a fair number of bucks. So they did that, and then he said, and you know, when we have a disaster in the rubber plant, you know those suits we put on? Those would be perfect, which they were. So they actually donned those like little suits that they would use in the rubber plant. And they actually have only, well, about 3 weeks ago, they were down to, about 1,000 people got infected, but they were down to 4 people, and they were all little boys, and they were brothers, but they were all doing fine. So they actually did the typical thing we do in public health: identify the case, isolate the case, find the contacts. It's not really rocket science. It's just hard if people don't know, who's infected. And it's a lot of work, as we know. It's a lot of legwork finding people that we think are contacts to people, but we always get our man. We're good at that. So the human to human, okay. If you don't remember anything, just remember a couple of things about Ebola. Is if I had the flu like right now, and I could have the flu, although I get my flu shot. If I had the flu right now, I'm infectious to you guys, but I don't know I have it for about a day or two. And then all of a sudden I feel like I want to die. Well, meanwhile, I've spread it. I didn't know I was spreading it. You didn't know I had it. That's how flu spreads. Ebola, you cannot get Ebola from an infected person unless they're sick. If they don't have a fever, you're not going to get it from them, because the viral load is so low at that point, you can't transmit. So that's in our favor. Because as soon as we see a febrile person that comes from an area that we know has that infection, we can grab them and isolate them. And that's the biggest ammunition we've got. And that's what we've been practicing. And I'll tell you a little bit about some of the stuff we've been doing in a bit. And then the spread, intimate contact with body fluids or tissues of a sick person or a corpse is the other thing that's caused it to continue to be perpetuated, is that there's a lot of rituals that people have in West Africa with a dead body, a dead loved one. There's a lot of preparing of the body, there's a lot of cleansing of the body, the family comes and touches the body, the children lay on the body, there's a lot of that. So when Ebola happened and the government said, okay, there's going to be none of that, we have to have these bodies cremated immediately, we don't want any viewing, it was really difficult, so people stayed away. They said, like, oh, we're not doing that, we're going to take our chances, it's not sacred to do that. So that's been a struggle, and it still is a bit of a struggle. The body fluids that concentrate, any body fluids the virus will get into, but particularly vaginal and seminal fluids, even after you're well, 90 days out, you can still detect virus. So it hangs around for a bit. So risk groups for transmission, of course, the healthcare workers, and we've seen that, and I think we've learned, and we were lucky that both of those young ladies did well. Anybody who touches the soiled, there was a lady in Spain who never had any contact with I think it was a priest who had been in Liberia. She had no contact with him. He came, he died. All she did was clean his room. But his garments and stuff were in there, and she packed everything up with her hands, and she contracted it. She did fine, actually, although they did put her dog to sleep because they weren't sure if her dog carried. Apparently dogs don't carry Ebola. We've learned that. So those folks, anybody that's healthcare provider, anybody that helps in the healthcare situation, and then funeral homes and people who dispose of bodies, they're at high risk. Family members, huge. We talked about that, caring for the sick. And you just know, if you've got a family member you care about more than anything in the world, you'll do anything to help them be better. And a lot of times it ends up in their death. And that's the whole touching of respect kind of thing that they do. So this is a bit to your point. Why has this spread so darn fast compared to the previous ones? And it's because the denser population, the roads are remarkably improved from the 70s. People go, you know how easy it is to go everywhere anymore. It used to be you had to walk everywhere if you were in West Africa. Now you can take mass transit. So when we all are all huddled together, we're more likely to exchange our personal viruses. There's also a lot of kind of fictional stuff going on. I was listening to a nurse in Liberia who runs a vaccination clinic, much like we have our public health clinics. They do a really, really good job at vaccinating kids. And the story went out that Ebola was being perpetuated by the vaccine needles, and that they were actually not giving you your mumps and measles and rubella shots and your Tdaps and your tetanus. They were actually injecting Ebola into you. And it was a big government conspiracy. So a lot of people stopped going to get their regular vaccinations, and they're still battling that one. It's just, you know how it is. We hear that somewhat here too. And the healthcare facilities, just not enough of them, not enough to handle all the people, and not enough protective equipment. And I don't know whether you saw that first slide where they look like spacemen. That stuff, and if you've ever put it on, which I'm sure not very many people have, it is, first of all, incredibly difficult to put on properly, incredibly uncomfortable and very hot. And if you've got the self-contained units, man, it's hard to breathe. And then if you gotta use the restroom in 3 hours, you have to take all that off and ditch it. It's gone. And you have to, the next team will come in and they have to put it on, so it's enormously expensive and it's in low demand. I mean, we're having this issue. We're trying to make sure we have enough protective gear for everybody that could possibly come in contact, which is why we're identifying specific teams of people who would be the first line responders, because we can't have protective equipment for every single healthcare worker. There isn't enough. It's in it, we try to order it and they say, oh, you're looking at January before we can get the masks, the hoods. And so we had to be conservative and say, okay, we're just going to have certain teams respond, which I think makes a lot of sense. We just had the folks from Emory who cared for the first nurse. They came up to my region, Middle Tennessee, and out at Wilson County Fairgrounds, and did a whole day of how to put on and take off protective equipment. And they were really good because they said, it's not just Ebola, it's anything. If someone comes into your clinic and just spews a bunch of bodily fluids, you should clean it up the same way as if it's Ebola. And so went through all that, how to do it, how to watch for the splatter, and how to put things on and off, and how to have a buddy to sit there with a checklist saying gloves first, next this, mask next. Because it's, if you have a mask on, I don't know whether anyone's ever worn a mask for a long period of time, boy, you get an itchy nose. You want to rip that baby off. And you have to have somebody always on you saying, no, don't touch, don't touch. So that's one of the things that we've recently done. And then there's this whole stigma. If a family has an Ebola patient in West Africa, the village knows. And then there's that stigma too. So people were keeping it hidden. I don't want anyone to know, because then they're going to, kind of will be outcasts. So there was that whole thing. Plus, the limitations in healthcare facilities. I mean, people were sleeping on the grounds. We pretty much what we said, here if you go into any emergency room or any clinic and say, I want my blood test, my blood count done, it's like that, you got it done. A lot of these facilities can't even run CBCs or chemistry to see what your electrolytes look like. So they don't have at all the ability to treat like we treat, which makes sense, and running water is an issue. And if you don't have running water that's clean, I mean, you're going to have another whole bunch of problems if there's anything contaminated in the water system. So these are the high-profile patients that you all heard about. Kent Brantley, who came back and did really well, and the nurse was Nancy, and then Rick Sacro was the fellow who did the Doctors Without Borders, who came back from New York, went to New York and went bowling and took 2 subways and 3 cabs and 356 contacts, a couple restaurants. And I thought, thank God it was New York, because that's a lot of people that you are now talking to every day for 21 days. I mean, they're getting worn out there. But this fellow we have already talked about, Mr. Duncan in Texas, and the story on him was that, and he wasn't completely truthful. He was in Liberia. He was in a car with a young woman who was pregnant, having seizures. He knew she had Ebola. He was taking her there was 3 other people in the car. They were trying to get her care, taking her from facility to facility, and they kept saying, no, we can't take her, we can't take her. By the time he was not sick when he flew to America. His family lived here, so the other people in the car had already died. Everybody in that car died. She died, the pregnant woman died, she kept seizing and she died before they could get her care. So, you know, the way I see it, this is a story I tell, I'm not sure if it's a story, but think of it if it was one of your family members. He calls home back here, he calls where his family is and says, everybody's dead, I've been exposed, I'm fine. And they say, what I would probably say, you need to get your butt here, because I think it's our best chance for you to survive. And he was untruthful with pre-departure folks, saying he hadn't been exposed, didn't know anybody who had it, wasn't around anybody sick. And so that, of course, wasn't truthful, but he knew it was his only shot, was to come to the US, because they'd already been successful. So that kind of part of me that says, gosh, if that was my family member, I mean, you know, you care about your family, you try to do what's best. And he was very ill. I mean, he went downhill pretty quickly. But all of those folks from the fellow with the Doctors Without Borders have all been released from their quarantines, and none of them contracted it. So the question is, what are we doing, and what's our risk here? And so we've gone back and forth. We've been on lots of conference calls with the CDC. Our state, we report, the way it works, health departments, like county health departments like you have here in Williamson, and then the region is where I work, so I'm responsible for my 12 counties and the 19 clinics and 33 healthcare providers that provide care for people, and then we report to the state, which is, of course, our commissioner is John Dreisner, who's military himself and emergency preparedness trained. He's a good guy. He knows what he's doing. He has common sense. So the state, we report to the state, counties report to us, we report to the state, and we all talk. Conference calls, thankfully not every day anymore, but every day at 1 o'clock we were always talking statewide. There's 7 of me in the in the state of Tennessee, and all 7 of us get together on a regular basis to say what's going on in West, what's going on in Northeast, how's South Central doing, how's Southeast doing, have you had any problems with this, that, what did you do if this happens? I mean, we talk, which is amazing. And we all like each other. And we get along. So this, I think, is the most comforting thing of all. So the response in the United States was, okay, how many people a day come from these 3 countries? And the answer is about 150 people a day get off the airplane, having come from West Africa. And they may be US citizens who have flown over there. Maybe there's a Ford plan, I don't know, and they're on business. Or there may be people who have relatives here. I mean, these are English-speaking countries. They're Christian countries. They have lots of family here. People come at this time of year to be with their families. That's very common. So 150 people a day, and 70% of them fly into the 5 airports like O'Hare, Dulles, LaGuardia, JFK. Can't remember which ones are which. I always say though that if you die and go to heaven, you have to go to O'Hare first. I think everybody in the world in the world kind of goes through there. So as soon as they get off the plane, the CDC meet every one of those passengers, and it's like, don't bother getting your bags, come with me. And they sit them down, and they have believe me, an exhaustive questionnaire. And before they get to go get their bags, they have to say, like, for example, let's say somebody came to Williamson County. Well, I have family in Franklin, and I'm going to be staying with Kathy Montgomery. She's my sister. Okay, we get every bit of information about Kathy Montgomery, and then they have to name one other person that's not a relative that knows their whereabouts, and then they're given thermometers to measure their temperature, and they're categorized as low risk, medium risk, or high risk. So if he said, well, look, I just was over there for 2 days. I was at my corporate headquarters for Ford, Liberia. I got off the plane, went to a conference room in a hotel, never went anywhere. So they'd be low risk. You know, I never went shopping, I didn't mingle. So they'd be categorized by the CDC as low risk. And then we would find out where they're staying, and if they're staying down on West Main Street, we would call them the first day and we would tell them, you have a responsibility to contact us. We need to be in touch with you. Find out your temperature twice a day. We need to visit you once in person. And at the end of 21 days, we need to finish off an extensive questionnaire. And so that's what's happening. And you know, nobody knows how many people are like that. There's been few and far between actually, because a lot of folks are realizing it's just best that they don't come. If they have family here for Christmas, a lot of people understand have canceled their Christmas plans to come and stay here, because if they're considered high risk, they're going to be stuck in their house for 21 days and someone's going to be watching them. I can't imagine spending all that money to be sitting in someone's living room for 21 days. So I think that's really helped, and I think the CDC that was a really wise move. So what happens is the CDC gets all that information, and then they send it to each of the state that's receiving passengers. So if it was to us, we have a state health operations center called the SHOC, which is in downtown at the Andrew Johnson building, and it's a pretty cool room. It's got lots of cool stuff in it, like the movies. We have one at the Regional Health Operations Center, which is called the Rock. Now we say, where's the Shrek? You know, we got the SHOC, the Rock, and the Shrek. But so what happens is that the CDC informs the state. As soon as the state of Tennessee people that we work with get it, they'll contact me and say, you've got 2 in your region. We'll contact whatever county it is. We have a disease investigation specialist at each one of our counties that does things like TB, HIV, tracking down salmonella or whatever the bug of the day is. So they'll call the person and say, I need to meet you in person. They drive to their house. They sit down with them. They do the questionnaire. And then they say, here's your thermometer. Do you know how to use it? They make sure they know how to use it. And they say, you have to call us every day with your temperature. And if we don't hear from you, we're going to come get you. And we will. When we do that really well. And so we do a lot of TB work in this region, and those patients we have to visit daily until they're not infectious and watch them take their medicines. We give it to them, we watch them take it, and we tell them, no going out of this house. You're self-isolated, and if we do hear that they've gone out and about without telling us, it's not pretty. I mean, you know, as a health officer, I can get a court order to put them in the Motel 6 for the next 4 weeks if we need to protect, you know, the population. That's my job. So we're good at that. And so that's what happens. And I think that's really important for people to know, is that it's just not, these folks aren't just getting off airplanes and dispersing. We know where they are, and everybody knows, and we track them. Yep.
Question.
Sure.
The 5 airports, are you saying those are just direct flights? Because didn't Mr. Duncan fly first to Belgium and then
Right,
indirectly?
and now you can't do that anymore.
Okay.
Yeah, well, as soon as you get a ticket to come to the U.S., you have to get a ticket that takes you directly to one of these 5 airports. You can't like meander to France and then, I mean, I guess if you ended up in France and you were going to say out from Liberia, although all those borders are really getting really careful as well. Even the countries right around those West African countries, like the Gambia, they have not had one case, and they're smack against Sierra Leone and the Ivory Coast, because I was talking to a fellow that actually spends 6 months of the year there, and he said they've closed the border to the rest of the countries around them. So they're taking a lot of personal responsibilities. But yeah, you just can't do that, Mr. Duncan to Brussels kind of thing anymore. Yeah.
Thinking how people used to fly to Canada and fly to Cuba.
Yeah, fly to Canada with TB for their honeymoon. That guy did that. Remember that? His father worked for the CDC in the TB division, and he was on his honeymoon, and he knew that he couldn't. He was in isolation. He flew to a different country, came back through Canada, got a rental car and drove home. But we found him. Yeah. So I've kind of explained that, how we visit them. And there's different levels of vigilance. I mean, some people are, if they're really high risk, they're not going anywhere. And you know that they parked police outside of people's homes. And I think that's okay if they're high risk, because it doesn't take much to spread. And then all that information is fed back into the database, and but several people have been trained to enter it into this database called REDCap. And so it's all the same single database. It's monitored all the time. So what else do? We do these things called tabletops, which is kind of like, we just did one for Montgomery County, which is a pretty big county. Of course, Fort Campbell's there. And that puts another little twist on it, because there's lots of people deployed to build the hospitals and so on. So what we did was we have a Tennessee Health Alert Network, which we all love because they always send out test alerts, and you got X number of minutes to answer them. You can do it through your cell phone or home phone or whatever. But the Tennessee Health Alert Network, we sent out one that a patient who presented to the front office of our health department. This wasn't real, this was an exercise, and said, I've been to West Africa and I don't feel good. And so we'd already done a whole dry run of what would you do. The clerk, even though it's not airborne, we don't know the person's got Ebola, they could have something else. Passed a mask to the person, said, stay right there. The nursing supervisor's called. She takes the patient to a designated room that has a bathroom and all the facilities that's away from everybody else, put them in there, called the emergency medical services and said, we have a suspect case of Ebola. So their team that was specifically trained to come pick the patient up came. That patient was transported to Gateway, and Gateway has been trained to receive in the emergency room. EMS calls Gateway and says, we've got a high-risk individual. They know how to reroute them through the emergency room. We've been doing that in all of our local hospitals. And we practice it sometimes just when we say tabletop without a fake patient, we'll do it just with each other, like different scenarios. We'll go through it, we'll be putting on and off the protective equipment, trying things out, making sure we do lots of dry runs, but you gotta practice all the time. It's a lot of practice. And the personal protective equipment, PPE, donning and doffing it, you have somebody standing right there. We just did a big exercise with a hospital group where our nurses went up and their job was to hold the checklist and watch them take it on, put it on and take it off, and make sure they were doing it in the right order and disposing of it properly in an area that was safe. Because one of the hospitals said, yeah, we're going to put all of our used protective equipment over here. And it was like, where everybody walks by, we're thinking maybe we have to find some other place. And even that stuff has to go, and it's like an inordinate amount of waste a day that if you actually are caring for patients, you have to figure out what you're going to do with that equipment, because it all has to be destroyed. And you have to figure out what to do with a body and what crematorium is going to manage that.
I'm just wondering, if the vaccine goes through, does that mean Ebola is going to be a thing of the past like smallpox?
We're hoping. And I can tell you a little bit about that in a second, actually. this is my favorite slide, and I always give, if you guys know Dr. Schaffner from Vanderbilt, if you've ever heard him speak, he's just a wonderful guy. He's been around for a long while, and he does all vaccinations and infectious. He's always on CBC or CBS and 60 Minutes and all this, but he's here at Vanderbilt, and he's this great guy. And a lot of these slides he gave to me, but he always says, this is the difference though, just to keep it in perspective. Ebola is new, good old flu is old. It's a little mysterious, we know what flu does. We don't know a lot about Ebola, we know a lot about influenza. It's deadly, it's often deadly. So I updated this today. We've had 11 hospitalized, we've had 2 deaths, and people kind of feel uneasy about it. Flu, annually, 200,000 hospitalized and 3,200 people die of flu. So that's when I say, you gotta get your flu shot, because it's really, it's gonna take a lot more people out than Ebola will. And avoid coughers. That's one really important point. Ebola is not airborne. You can't get it from someone coughing on you. People say, well, what if they had tons of virus and I guess he conceded, okay, if you had tons of virus and they coughed a huge glob in your eye or straight in your mouth, okay, you might have a chance, but typically you can't get it by coughing. Flu, man, you can get flu. I mean, if you've ever seen that picture of how much you spray with a good cough, it's pretty scary. So that's my little get your flu shot thing. Okay, so just in summary, we feel like we're pretty ready for this. We're training and we keep training. We change as things change, and we recently just got a 21-page, full-size pages document for the hospitals are all going through 21 pages of what to do in certain situations. Do you have this available, that available? And as a department, we go meet with them and go over the list and say, can we help you in any way? We're really there not to run the hospital show. That's what they do. We're there to help them in any way that we can. And then we talk. You got to talk to each other, and we do that. We had an Ebola conference call at 1 o'clock every day for how long? Way too long, it seemed, for weeks, and it was booked through to January 1. Now we're doing Tuesday, Friday right now, because we feel like we've kind of got things under control. But if it picks up, we'll just pick it up again every day. And you just have to always be in communication. I mean, I get tons of emails every day with new stuff and what are we doing next, and have you reported this or that, or more training, and we just practice. So let me talk just really quickly. So they added Mali as one of the countries today, I think this morning. So this infusion, you've heard people getting infused with the infected blood of survivors, and that's nothing new. I mean, if you have a hepatitis A case and you have a baby, or let's say measles, for example, that's a good example. Measles, we don't start vaccinating kids for measles till they're 6 months. So 6 months? Year. I can never get it straight. If a child, this happened actually in this county, it happened that the parents had a death in the family overseas. The baby was 3 months old. They flew over. Measles is endemic in France because people don't believe in vaccinations. India, you get immune by having measles when you're a little kid. Here, no one has measles anymore. I mean, I had them. I always say my immunity did not come from vaccination. I had mumps, measles, and rubella, because I'm telling you my age. But, people that are younger get vaccinated. Some of us just all got the diseases, and that's how we got it. This little baby came back on the plane, broke out in the rash with a fever of 104. And, of course, then we had to track down. Went through O'Hare. Yep, went two cities in India, O'Hare, and that entire wide-body jet dispersed across the United States. So the CDC has groups of people that can track really quickly the flight manifests, and we had 5 that came to my region from that airplane. And one of them actually was exposed. This little this little baby was in one of the offices here in Williamson County, not our health department, but a private office. And while they were waiting to be seen for the rash, a 3-week-old was in for their new baby physical. Measles is the most contagious disease on the face of the earth. If anybody here was not immune and someone walked against that wall, you're going to get it. That's how contagious it is. And so when we found out this 3-week-old had been weighed at the central weigh station before they realized that this kid had measles, we had to track that child down. Well, we can't vaccinate, so what do? You give immune globulin, which is the immune factors in the blood of people who are immune. And that's essentially what they do. They took the blood of people who survived and they, I guess, kind of swirled it around and strained it out and got the globulins that caused the immunity and injected it. Yeah.
Sorry, another question. I couldn't help wondering, why in the world wouldn't the French believe in vaccination?
Well, it's trendy. There's trends. I don't know why. There's one part of France where everybody's decided, what happens is that people don't get the communicable disease because so many of us are vaccinated that you get what we call herd immunity. The herd's vaccinated, so if one calf is the only one that isn't, that calf's not going to get sick because we're protecting them. And then some people, during the whole thing about autism and all of that, people said, I'm not getting my kids vaccinated, and then they started getting a couple cases. We just had a big outbreak in the Amish community in Pennsylvania because they don't get vaccinated. And it was horrible, actually, because we had usually about 12 cases of measles a year. I think we had like 500 and something last year. It was huge. And adults with measles is ugly. They get really sick. I mean, you can get really sick. So Amish now believe in vaccination, so they have all been vaccinated. But that's why that people trend with, we don't think we need it or whatever. And then when we get an outbreak, people go back to saying, yeah, maybe we need to be vaccinated again. So that's what happened with that. But this little girl with the measles, this 3-week-old we found in, I think, Lawrence County. We had to track mom down, and she came back and we had immune globulin. She met us at your health department and we vaccinated the child. She did not get it. One baby that was on that plane from Texas got measles because they couldn't find that person. I think I tracked down 5 people. All of them were born, 4 of them were born before 1958, which you presume you're immune if you were born before then, just because of the vaccination patterns. And then one guy, 33-year-old fellow, he had had one MMR. He hadn't had a second one, which put him at risk. And we only had something like 36 hours to find people before it was too late. We found him in Murfreesboro, and then he was a big baby and didn't like needles. And anyhow, we talked him into it, and at the midnight hour, he put his arm up and got the shot and said, well, that was nothing. Yeah, but that's what we're looking at that. And vaccinations, really fascinating. There's a Canadian company that's got a vaccine that's being tested. Johnson & Johnson, who is arch enemies with apparently GlaxoSmithKline, have paired together, and they're hoping to have some preliminary vaccine available in the new year, which won't be huge quantities and will be given to the highest risk people, which will be healthcare providers in West Africa. But I do expect that this also will become a thing of the past. And the question was, why didn't we do this sooner? And the answer is that it wasn't a big enough problem. There's one fellow in Liberia, a physician, who is using HIV medicines, and those are antiretroviral drugs, and it's a virus, and he said, what do we have to lose? It may have some effect on the viral load. So he's trying that, and there's 2 antiviral drugs for presumably influenza that are in development, and they've given it to 1,000 people who have said that there's no side effects at all, so they're going to give that a whirl. I mean, they're going to just try it because really at some point you have nothing to lose. But we're hoping the vaccine, I don't think January's really a realistic date, probably be later than that, but I expect that we'll see that. There's one of those big concerts, remember they do those guys, can't remember which groups get together and they do concerts to raise money for, hunger and all that. They've announced tonight that they're doing Ebola concerts to raise money to help get things moving along. So as a actually world community, people have really pulled together, and I do think we're getting it under control. I think our risk is extremely low in this country, and I think it's a lot of time and effort's gone into the preparedness for this, but it could be for anything. We said the other day, look, we've all learned how to be prepared for the worst case scenario. Now, a less worst case scenario will really be prepared. And there's a lot of money from 9/11 for emergency preparedness that we still have, and that was the purpose of it. So we're still doing that. I think that's a good thing. But I do feel pretty comfortable that we're where we need to be, and we're prepared enough to know certainly what not to do. And I don't think our risk is huge. I really don't. Does anybody have any other questions? You were always one slide ahead of me.
Why do they think it comes from bats? I mean, don't,
Pardon me? Why?
why do they think bats? Didn't South America have fruit bats?
I don't know. I have no idea. And it might not even be deadly to them. Must not be, because they're still fruit bats. And they're big. They're kind of cute, actually. Except for they are telling the people in West Africa not to pick fruit up off the ground and eat it, because kids do that. And I guess the bush animals or the wild animals are the things that they're telling them really not to slaughter and eat on their own. Sure.
You mentioned that, like with TB, you
Mhm.
can have police sit outside someone's house to make sure they're complying. With like the example you gave with the measles and the guy that didn't want to get the vaccine, what kind of power does the health department have to make them get the vaccine? Like, would you have to get a court order, or?
Yeah, well, you can get a court order that, like, as a health officer, I have the ability to do that. There has to be risk. Like for him, the biggest risk was for himself, because, sitting in Rutherford County, if you took a 10-square area around his home, probably everybody was vaccinated or immune. If it was something that was like everyone was susceptible to, that's a whole different thing. For tuberculosis, we every once in a while have a patient who has tuberculosis and is still spewing. When we do sputums all the time and we check and see if it's still there, and if it is, they have to be isolated. And most people will self-isolate. And if they do go, even I've gone and given directly observed treatment to a patient also in this county. And when I got there, she was wearing her mask, and the family was, they were all fine, and we tested the family and everything. But every once in a while, someone will, like I remember was one story, this fellow, he drove a car that was really unusual. I think it was an old car or a pink car or some weird colored car. And the nurse who was doing the DOT, or directly observed treatment, every day, she knew his car. And she was driving to his house, and she drove by this restaurant, and she went, his car is parked out there. So she walks in and she walks right over, no mask on, she walks right over to him, grabs him. What are you doing? And he's like, oops, she pulled him out of there. And so we'll say, look, if you're not going to comply, we will put you someplace. We can put people in a hospital setting until their sputum's clear, because it's risky. Tuberculosis is, it's not real easy to get, but you don't want it. You're looking at 9 months of treatment or longer. So we do have the ability to do that if there's a risk. If there's any risk to the public, we can quarantine that person. I think with the lady in Maine, the police actually, she made a lot of noise about, I'm not going to self-isolate, I'm not going to, and so they just parked the police outside her house, and I think she's out of isolation now. There's a lot of pros and cons to that, but I think self-isolating for the public's safety and to stop hysteria is probably worth it. But we always get our man every time someone goes AWOL. There's a fellow in the downtown office that can find anybody like that. And thank God for Facebook. People cannot resist. They cannot resist. I mean, the other day, we're looking for someone the other day, and I said to Dr. Goodson, hey, I emailed her, I said, hey, can you do your Facebook thing? And she's like 3 minutes later. Yeah. Got him. Got him, tracked him down, and then he was like, he was out of the country. And so, but he had all his family on Facebook, so, and their names and where they worked, and I just called the guy up at his place of employment, and he was like, holy smokes, you know, good old Facebook. And for sexually transmitted disease, we do the same thing. We have to track down contacts, and people don't know who their contacts are, but boy, they'll write on Facebook, hey, guess what I just tested positive for? And all the people start going, are you kidding me? So, you know, I mean, that's, social networking has its advantages for public health. You guys good?
Because the library's getting ready to close in about 3-5 minutes.
Oh.
Okay, well, we'll be out of here.
Yes.
Okay, well, thanks, guys, for coming.
Thank you.
Today's custodial profession requires a high degree of knowledge and skill. Career Solutions offers an intense 2-week custodial certification program designed for those interested in this line of work. This free program is based on the nationally accredited Cleaning Management Institute curriculum, teaching skills in all areas of commercial building cleaning.
This is something that can never be fully automated. It can't be shipped overseas. These jobs are right here, right now.
Students will be taught the newest custodial technologies and procedures, as well as the operation of cleaning equipment by a CMI certified trainer. Not only are program graduates job ready upon completion of the course, but they are also provided with a letter of referral and graduation certificates.
Once the program is finished, we actually have some companies like SMS and several other companies that will hire people that graduate from this program to give you all the tools and resources to find a job in custodial services.
If you're interested in learning more about Goodwill's Career Solutions Custodial Certification Program, visit goodwillcareersolutions.org.
In uncertain times, what can you be sure about? The sun rises in the east. What goes up must come down. Night follows day. Well, here's something else. When it comes to dealing with debt collectors, federal law gives you rights. For example, debt collectors can't call before 8 in the morning nor after 9 at night. Can't curse or insult you. Can't demand that you pay more than you owe. Can't lie about anything. They can't say that papers they send you are legal forms if they're not. Nor can they make up consequences for not paying your debt. And they can't call you at work if your employer doesn't allow it. You also have the right to stop debt collectors from calling you. How do you do that? You have to notify them in writing. Sending them a letter should stop the phone calls, but of course, it doesn't wipe out your debt. There's helpful information about dealing with debt at ftc.gov/moneymatters, a website from the Federal Trade Commission. It explains the rules of behavior for debt collectors. Take a look. There are some that may surprise you. If your debts have gone into collection, remember that you have rights. Asserting your rights doesn't make your debt go away, but it does give you a voice. The more you know about how to manage your debt and deal with debt collectors, the better off you can be. After all, money matters. If you think that a debt collector has violated the law, report it. File your complaint with the Federal Trade Commission at ftc.gov/complaint. Your complaint gives law enforcement a lead to follow up on and may stop it from happening to someone else. The Federal Trade Commission is the nation's consumer protection agency. For more tips on credit and debt, visit ftc.gov/moneymatters or 1-877-FTC-HELP. 1-877-382-4357.